Okay, in this recording, we are going to look at the spinal cord. In a previous recording, we have already done the brain. So it's really good to kind of look at the brain and the spinal cord together, which again is the central neural system. So when we look at this torso model, we get a pretty good idea of seeing the spinal cord starting in the neck and going down somewhere to the lower back. But what is important to understand is that the spinal cord really doesn't go all the way down to the sacrum or coccyx. The spinal cord actually ends at the L1, L2 interspace. So here's a vertebra. We cut the lamina like a laminectomy, which removes the spinous process. And then we can see the cord and we can see some of the spinal cord and the nerve roots. So at L1 and L2, this is where the spinal cord ends. And there is a region that's called the conus medullaris. The conus medullaris is a tapering of the spinal cord, and we can see it right here. It looks like the apex of an ice cream cone. It comes to a point. That's called the conus medullaris. After the spinal cord ends, what we have inferior to it is something called the cauda equina. Cauda equina literally means horse tail, and that's what this looks like. These are nerve filaments that come through the lumbar and sacral region, but they're all nerve roots. It's not spinal cord, which explains if there's ever a spinal tap that needs to be done or an epidural that needs to be done, they do it below the spinal cord. They'll come down perhaps at the L3 vertebra, have the patient bend forward, separate the spinous processes, and inject a needle in between the L3 and L4 region because the needle has no chance of hitting spinal cord. In the cervical region, there are 12 pairs of cranial nerves. In the thoracic region, there are 12, I'm sorry, in the cervical region, there's 8 pairs. In the thoracic region, there's 12 pairs. I'll also show you a close-up view of the meninges. Here we can only see 2 layers. The meninges protect the spinal cord. So there's the dura mater. A little bit deeper to that, we can see here's the dura mater, here's the dura mater. And if we hone in a little bit, we can see the middle layer, which is called the arachnoid here. In the cervical region, I will show you that we have 2 plexi that come off of the cervical region. One's called the cervical plexus, the other is called the brachial plexus. In the lower back, we have a lumbar and sacral plexus, which I'll show you shortly. But there is no plexus in the thoracic region. The thoracic region just has intercostal nerves. These are nerves that go to the ribs and the muscles between the ribs. So here's a close-up view of the L1, L2 region. We can see that the conus medullaris is the tapering of the spinal cord. And then there's an extension that goes right down to the coccyx. That extension is called the filum terminale, the filum terminale. The cauda equina is just the horse's tail. These are all these filaments. It really does look like the horse's tail. Here is the cervical enlargement. Cervical enlargement because there's a lot of nerves that come out of the neck. One is the cervical plexus, the other is the brachial plexus. Here is the outermost protective covering of the spinal cord called the dura mater. It's very, very close to the bone. Dura mater means tough mother. And then here is the arachnoid mater. The pia mater would be a membrane that covers the spinal cord closest to and contacting the spinal cord would be the pia mater. I'll show you those 3 layers here in this cross section coming up in the next slide or 2. Here is a cross section of the spinal cord, and we can see that the spinal cord is protected by the vertebrae. This happens to be a cervical vertebrae because we can see the bifid spinous. Once you see the bifid spinous process and you see the vertebral bodies, then we know that anything, if we were to divide the spinal cord in half, anything on this half is posterior, and anything on this half is anterior or ventral. That will help us identify some of the structures. Another key landmark, if we don't see the spinous and we don't see the vertebral body, to help us differentiate dorsal from ventral, we can look here at the spinal nerve. This is the spinal nerve, and it has two divisions. If I zoom in, you could see 17, 18, and 19. 19 is this large, swollen portion of this nerve, but this is a ganglia. Remember, a ganglia by definition is a group of nerve cell bodies in the peripheral neural system. A nucleus is a group of nerve cell bodies in the central neural system, but a group of nerve cell bodies in the peripheral neural system is called a ganglia. So this is actually called the dorsal root ganglia, the DRG, the dorsal root ganglia. This is the dorsal root ganglia that's connected to 18, called the dorsal root. So the key word here is this is dorsal. So everything back here is on the posterior side. 17 is the ventral root or the anterior root, and that comes in here. So everything on this side is anterior. Just another way of looking at the spinal cord and identifying anterior from posterior structures, just like these two, which is the posterior median sulcus and the anterior median fissure. So the PMS, the posterior median sulcus, is here. That's that separation or groove here. Looks like number 29. And then here, number 25 is the anterior median fissure. All right, let's look at the three meningeal layers. So here is the spinal cord, and here's 1, 2, 3 layers. So it's pad, PAD, from inside to outside, it's pad. So here's the pia mater, that's this layer all the way around that protects the spinal cord. Then the middle layer is the arachnoid, looks like number 16, I believe here. And then number 8 is going to be the dura mater, which is the outer layer. So we have PAD, pia mater, arachnoid, and dura mater. Those are your three meningeal layers. Now we have spaces between those meninges. So here, again, is the pia mater. Here is the arachnoid. Now under the arachnoid, underneath it, is the subarachnoid space. This is where cerebral spinal fluid is going to flow around, right? When it leaves the lateral apertures, it's going to go through the subarachnoid space. When it goes in the median aperture, it's going to go down the central canal. So this is the subarachnoid space. That's where your CSF is going to flow and bathe and help cushion and buoy the spinal cord. Now here, number 9 is the dura mater. So between the dura mater and the arachnoid is the subdural space. Above the dura is the epidural space, right? The epidural is made up of a lot of fat. There's a lot of blood vessels in here, and adipose, again, another layer of cushion on top of the cerebral spinal fluid to help support any type of concussive force that may be coming into the spinal cord. Okay, now remember when I showed you the brain in an earlier video, I said that there's white matter and gray matter. And in the brain, the gray matter is on the outside and the white matter was on the inside. Well, on the spinal cord, it's opposite. The butterfly, or the letter H in the middle, this is gray matter. And everything around it, supporting it, this is all white matter. Gray matter, white matter. Now, the white matter is where all of your tracks are. What are tracks? when we talked about the brain and I showed you the precentral and postcentral gyrus, I said the precentral gyrus was where all of your motor or efferent information, which descends, originates. And I said the postcentral gyrus is where all of your sensory tracts or ascending information, where it will finally end up in the brain. Well, in the white matter is where the ascending and descending tracks, the upward and downward elevators, where they are. And you will learn their names when you cover them in lecture, like anterior spinal thalamic tract, lateral spinal thalamic, anterior corticospinal, lateral corticospinals. You'll learn about all of these different tracks, vestibulospinals. Okay, what else do we have here? In the gray matter, we have horns. So this is posterior because here's the spinous process. So that's the posterior horn. Here's the anterior horn. Here's the lateral horn. The other names would be dorsal horn, ventral horn, or lateral horn, or posterior and anterior horn. They're interchangeable. The crossbar going across this way is called the gray commissure. Remember, this is all gray matter. So this is the gray commissure going across. And the hole right in the middle is the central canal. Now, these horns are gray matter. Now, around it is white matter, and we have columns. So on the posterior side, we have posterior white columns or posterior columns. In the front, we have anterior columns. And on the side, we have lateral columns. The columns are white matter. These are all myelinated, and these are where your tracks are. These posterior columns or these posterior or dorsal columns are really important. They're involved with proprioceptive awareness. What do we mean by proprioception? It means that you know where your body is in space and time. That's what that means. The posterior columns is also involved with vibration, the feeling of vibration, 2-point discrimination, being able to tell if someone takes 2 fingers and they touch you somewhere on the back that you know that you're being touched in 2 different places. It can tell the difference between, let's say, someone drawing a number on your back or a letter on your back, that game that maybe people would play when they were young kids and you would have to guess what that was. That's called graphesthesia. Those things are controlled by the posterior columns. Okay, so posterior columns, anterior columns, lateral columns, white matter is on the outside, gray matter is on the inside. Again, let's look at the gray matter. Post-dorsal horn, ventral horn, lateral horn, that's gray. On the white side, anterior column, posterior column, anterior column, lateral column. Now let's look at the anatomy of a spinal nerve. Now the spinal nerve is here, right? This section where there's no arrow yet that's pointing to it, this here is the spinal nerve, and a spinal nerve is considered to be mixed. It's mixed because there's a sensory and motor distribution to it. So when we look here, we can see this is your dorsal root and this is your ventral root. This is your dorsal root ganglia. Sensory information comes into the back, into the dorsal horn, and from the ventral horn, motor information goes out. So sensory comes in the back, motor comes out from the front. Right? It's like a circuit. So the spinal nerve, which is here, is mixed because there's a sensory nerve root, which is the dorsal nerve root, and then here's the ventral root or the anterior root. The swollen part is the DRG, the dorsal root ganglia. So again, if you don't see the spinous process or vertebral body, and you just see the spinal cord with these two nerve roots, always remember that the swollen part is the dorsal root ganglia, and there's the word dorsal. So if that's the dorsal root ganglia, this has to be the dorsal root. The smaller ones are called rootlets. So these are dorsal rootlets right there, and these are ventral rootlets. Okay, the larger one are roots, the smaller filaments, those are rootlets. Rootlets, they sound smaller, right? Rootlets. And again, here's the spinal nerve. Now in this picture, we can see the spinal nerve, and the spinal nerve itself has two branches coming off of it, one going to the back and a larger one going to the front. The one going to the back is the dorsal ramus. The one leading to the front is the ventral ramus. The ventral ramus is going to give rise to all of the major branching networks in the neck and the back called the cervical plexus, the brachial plexus, the lumbar plexus, and the sacral plexus. So all of those major plexi are going to come from the ventral rami. That's why they're so large here. Okay, so now we're going to look at the spinal nerve again, right? So we showed you here the dorsal rootlets, the dorsal root ganglia. Here's the ventral root, ventral rootlets. We said here is the spinal nerve, and here is the ventral ramus. Now the ventral rami are going to give rise to the cervical plexus in the neck, the brachial plexus going down the arm, the lumbar plexus going down the lower back, and the sacral plexus that creates nerves that go down the leg. So all of these plexi are going to control muscles of the upper extremity and the lower extremity. So the plexi is really, really important. Now this model we're going to refer to as flat Stanley. So those ventral rami that give rise to the plexus, we're going to talk about some of their nerves now. So in the neck, there's two plexus. The first one is the cervical plexus, and the cervical plexus mostly has branches that go up to the neck and up the skull, but there's one important one that goes down called the phrenic nerve. The phrenic nerve goes to the diaphragm. Okay, so this phrenic nerve right here comes from C3, 4, and 5. And you can remember that C3, 4, and 5 keep the diaphragm alive. C3, 4, and 5 keep the diaphragm alive. It goes to the diaphragm. Now the brachial plexus goes from level C5 to T1. C5, C6, C7, C8, and T1 nerve roots that we can see here. C5, 6, 7, C8, and T1. These nerves are going to go down the shoulder, down the arm, and go all the way down into the fingers. These are the main terminal branches: axillary nerve, musculocutaneous nerve, radial, ulnar, and median nerve. These are the terminal branches of the brachial plexus. So here on flat Stanley, we can see the beginning of the brachial plexus on both sides from C5 to T1. And we're going to look at some of their terminal branches here. The one going to the deltoid and teres minor muscle is the axillary nerve right there. The one going to most of the muscles in front of the humerus in the arm is the musculocutaneous. So that goes to your biceps brachii. It goes to your brachialis, most of your elbow flexors. Now we have an ulnar nerve that follows the ulnar bone. We have a radial nerve that follows the radial bone. And between both, we have in the middle is the median nerve. The radial nerve goes to any type of muscle that's going to extend, like elbow extensors, wrist extensors, finger extensors. That's all controlled by the radial nerve. In fact, I've had several patients over the years that had a condition called wrist drop, where they just couldn't extend the wrist due to birth trauma, in fact. There was pretty severe trauma to the cervical spine during delivery, and they had damaged the nerve roots that give rise to the radial nerve. Radial nerve is responsible for wrist extension. So if you can't extend the wrist, the opposing muscles kick in, all the wrist flexors, and flex the hand. If the radial nerve was intact, you could oppose that and extend it. But since it's not, boom, all the wrist flexors kick in and you get a condition called wrist drop. Median nerve is important. This is the nerve that's involved with carpal tunnel syndrome. Okay, let's move on to the lower. Actually, let's look at the thoracic region. So the thoracics don't have a plexus. They only have intercostal nerves. So here in the thoracic region are 12 intercostal nerves. These are the nerves that go in between the ribs to the intercostal muscles. Oftentimes, the intercostal nerves are attacked by herpes, herpes zoster, aka shingles, where the herpes virus lives here in the dorsal root ganglia. And when one's immune system becomes weak, you start to get blisters and pain that follow the path of the intercostal nerves or any dermatome for that matter. All right, in the lower back from L1 to L4, this is the lumbar plexus, and then the sacral plexus is from L4 to S4 down below. The two major nerves that come off the lumbar plexus are the femoral nerve. This femoral nerve comes down here and goes to the quadricep muscles for leg extension. The obturator nerve, which we can see one here going through the obturator foramen, and this one here. So this nerve here is the obturator. That goes to most of the muscles of the inner thigh, like all of your adductors, adductor longus, adductor magnus, adductor brevis. Anything that's going to bring the thighs or the femurs in is adduction. That's the obturator nerve. From L4 to S4 is the sacral plexus, and the infamous nerve here that originates there is called the sciatic nerve. Sciatic nerve is really important nerve. You could see it here in this view in the back of the leg, right? If we look, we see the foot really rotated out. So we have a good perspective of what's in front and what's behind. So here's the sciatic nerve. And then right behind the knee, we can see that it splits. It splits into a tibial nerve, aka the posterior tibial nerve. And then the other nerve that it splits into is something called the common peroneal nerve. The common peroneal is right up here, and it splits. And the common peroneal nerve can split into a deep peroneal and a superficial peroneal nerve. The deep peroneal nerve goes to, which you see here, it goes to all of the anterior compartment muscles of the leg. So anything that's going to dorsiflex the foot is deep peroneal nerve. Anything that dorsiflexes the foot is deep peroneal. And that begins at the L4 nerve root in the lower back. So remember, L4 dorsiflexor tibialis anterior, right? Tibialis anterior is your primary dorsiflexor. So L4 tibialis anterior dorsiflexor. The superficial peroneal nerve stays superficial, and it's really sensory. It does sensation to the outer leg and the outer foot. When you sit with your legs crossed, and sometimes your toes go numb, it's because you're compressing the superficial peroneal nerve right here, kind of like at that head of the fibula. You can compress part of that superficial peroneal nerve. Okay, the posterior tibial nerve is your plantar flexor, but the deep peroneal nerve does your dorsiflexors. So there are some people that get a condition called foot drop, where the foot literally drops due to damage to the tibialis anterior or the deep peroneal nerve. And that comes from an L4 issue. The posterior tibial allows you to step on your tippy toes. That controls the gastrocnemius and the soleus for plantar flexion. So if you can't plantar flex, then perhaps there's weakness to the posterior tibial, and that begins at S1. S1, sacral segment 1, that nerve, S1 does plantar flexion. S1 does plantar flexion, but L4 is your dorsiflexor. Okay, and the last concept here is going to be the reflex arc. So the reflex arc is like if you touch something sharp or hot, there's a reflex that happens so quickly and it allows you to pull your hand away from that painful stimulus, like a thumbtack or something. So there are 5 components to a reflex arc. 1 is the receptor. 2, the information goes through a sensory neuron. 3, it's going to be processed with this interneuron, aka association neuron. The interneuron relays it to the ventral root, and the ventral root sends it out to the actual effector, the thing that's going to be effected. So when we look at a plaque that has the different components of a reflex arc, something's going to touch the skin, it's going to stimulate a receptor. Then we have the yellow nerve, which is the sensory neuron. It's going to relay it to an interneuron. They call it an integrating neuron, but really the term should be interneuron. That's the third part. The fourth part is the motor neuron. And the motor neuron will finally end up at the effector. In this case, the effector is the muscle, but it is an effector. This part here is the dorsal root ganglia. This is your dorsal horn. This is your ventral horn. So from the anterior horn or the ventral horn is where the nerve cell bodies are for the motor neuron. Okay. And what we'll finish with here is the neuron. In fact, we'll start that in another video. So let me stop this here.